show you the slide, I think that you could not understand which is residual, new, or recurrent varicose vein. But when we have to study this patient, we have to study reflux. So etiology, distribution, and extension of reflux is very important to assess the patient pre-op. Now we have to check out what we are operating patients. So the thermal and vascular techniques, and to mention is RFA, laser, steam, and the no thermal, what you see downstairs. And the open surgery can still be divided in stripping, but with high ligation, and stripping. And the stripping can be long, short, ultra short. So we have to better analyze our preoperative data. And then we have conservative techniques like SIVA-ASVAL and ambulatory phlebectomy. The big problem of recurrent varicose veins following surgery is because it occurs from 13 to 80% of the cases, and it is attributable to causes including inadequate treatment, disease progression, and avascularization. This is a debilitating and costly problem. And now let's see the definition of residual veins, that are veins that were already present in the operated sites at 1 month follow-up examination, and they were left as a result of technical error. While the recurrent varicose veins are absent in the operated area during the first month follow-up examination at the level of the operated site, but subsequently appear either as a result of neovascularization, as a result of technical and tactical error. And the new varicose vein, the new disease, is evolution of disease that was not present at the first month follow-up, but developed later in untreated areas due to disease progression. And let's see the most common causes for residual varicose veins. That is anatomical variability, erroneous diagnosis, tactical and technical errors that can include inexperienced surgeons, incorrect vein mapping. Then we can have extension, massive extension of varicose vein disease, not saphenous vein. Strategy of treatment. Some surgeons try to operate in 2 and 3 steps the patient, so the patients don't go back to the surgeon and comes to me, and I say, okay, this is residual or recurrence, but these patients were not treated before. Lack of ultrasound-assisted surgery. The causes of recurrent varicose veins are tactical and technical errors, neovascularization, recanalization, and progression of disease for what concerns the new disease. What we have to do before operating a patient is the duplex scanning, pre-op, during, and post-treatment, because we have to determine all the sources of venous reflux, identify the anatomical variability, venous mapping before surgery, monitoring the operation during the treatment, accurate follow-up. And this is what we already said, the reflux, the extension of the reflux, the result of an obliteration of the great saphenous vein. Sometimes we don't know about tuberculosis, and some surgeons cannot well operate the patient because some J-guide wire cannot get inside the tortuous vein or angled veins. And sometimes we have an aneurysmatic deep vein system that determines reflux, that also it can be a cause of a superficial vein reflux in the follow-up. And sometimes the extension of the disease is so massive that we cannot, it is normal not to exclude all the varicosities from this cuff. And sometimes we can see small veins, and as you can see here, we have perforators that determines reflux and that pick up the backflow from the popliteal vein or the femoral vein. Sometimes the anatomical variability, the gemellar veins, but what you have to do once you have scanned your patient is to determine whatever you saw in a paper. So you can have the vein map of the patient, and these are the 3 steps how is my policy and my group is working. Whatever is visible and palpable, we have to map it immediately before operating. Then we transilluminate with laser all the leg and scan it to see if there are any collaterals that they're not visible. Then ultrasound in the pre-op, and what you have to do is to mark with a marker on the skin of the patient whatever he has. Aplasia, hypoplasia, great saphenous vein reflux, the great saphenous with the tributary on the lateral part, great saphenous plus accessory, only the accessory because the great saphenous is normal, the small saphenous vein reflux, and whatever you have to do with the patient, you have to do it under ultrasound. Ultrasound that and with the techniques that we know. Now some kind of tip and trick. I have some troubleshooting when I do tumescent anesthesia to see where to put the laser tip below the epigastric vein. And I saw that the B-flow, the blood flow motion with the ultrasound can help you to identify where is the epigastric vein, and here you can see it better. And when I do the ablation, I want to know if I close the epigastric vein, if I have any problems. So it helps at the same time. Then I checked if I have done the obliteration, the correct obliteration of the trunk, because as Bichot assessed in this publication in 2000, the type 3 is more likely to become a recanalization with collateralization of the tributaries, okay, and give again start the new disease. In all these endothermal techniques, we know that is from 2 to 12% the rate of recanalization. And another tip that I'm doing it always is to assist with ultrasound also the phlebectomies. Once whatever you mark is off, then please check with the ultrasound probe if there are any residual varicose vein. This is an excellent obliteration, and this is what 12 months after EVLA can see your saphennic tunnel, so this is fibrosis. And this is what is the study that I have done in my group. We studied 337 patients in a 10 years follow-up to assess venous reflux that comes from the great saphenous vein, the accessory vein, and the small saphenous vein. The mean follow-up was 88 months, and the recurrent plus new disease was 33.9%. One-third of the patients that we operated at 10 years had new disease, but we didn't operate them all of them. The partial recanalization was the most common pattern of recanalization. It was related to drainage from tributary perforators, large vein diameter that we treated with laser, inadequate local energy delivery, thrombosis development, neovascularization. That is very uncommon for the endothermal techniques, but very often for the high ligation and stripping. Complete recanalization due to inadequate energy delivery, large vein diameter, and thrombosis development. And as you can see here in the first follow-up, we had only partial and asymptomatic recanalization in 3.4% of the patients, but in the late follow-up at 88 months, we had more recanalization and complete and symptomatic for a 3.4. These 3.4 were the patients that we operated again because they were symptomatic. And as you can see in this slide, the new disease can start in the thigh or in the calf or both of them, and it can start due to perforators or other collaterals or recanalization. And sometimes you can have recurrent varicose veins due to no saphenous vein reflux. You can see here the residual at your left after high ligation and stripping, and the new reflux that starts when from the accessory vein. The residual plus new disease, as I said before, it was assessed at 1/3 of the patients, 33.9%. 27 were asymptomatic and 6.8 was symptomatic. And now just a tip for functional and spine postural analysis that we're checking out with my group, because there are two indications that were all well operated, but in the follow-up demonstrate an extraneous varicose recurrence. So we're just checking now for the postural analysis of the back and of the feet, if they are working. The altered baropodometric examination in patients with varicose veins, it can be another way to understand why it happens, the recurrence. And as it can show you this slide, people can also have ulcers without varicose veins, only due to hypertension, because they cannot walk very well. So my conclusions is that the great saphenous vein partial recanalization at 2 months in our study was at 3.4% and asymptomatic. The complete recanalization was null. The great saphenous vein complete recanalization, the low follow-up was 5.1, and it was asymptomatic in 1.7 and symptomatic in 3.4. The reduced surgery was mandatory only for symptomatic patients. The residual varicose veins after surgery, recurrent varicose veins after partial or complete recanalization of the great saphenous, it was 11.9%. That is, you can see in other publications same numbers. The recurrence after surgery plus new disease in the late follow-up was 33, 1/3, I repeat it again, and we reoperate 6.8% of the patients. The treatment of choice for reduced surgery was ultrasound-guided foam sclerotherapy plus phlebectomy. Thank you very much.